For so many women who are managing chronic health conditions, pregnancy brings up a really complex set of choices, right? How do you protect your own health, but without adding risk to your child? Well, today we are breaking down a landmark study that gives us the clearest answers yet on anti-seizure medications in pregnancy. And it uses data on a scale that is, well, it's almost hard to believe. Okay, let's get into it. So, get this. The number of pregnancies that were analyzed was 16.9 million. To be super precise, 16,941,373. This isn't just a large study. It is one of the most comprehensive systematic reviews and meta-analyses ever done on this subject. And that sheer scale, it gives its conclusions an incredible level of statistical power and authority. So here's how we're going to break this all down. We'll start with an overview of this massive study. Then we'll look at the top-level risks that it identified. After that, we'll dive into what is maybe the study's most groundbreaking insight, finally separating the risk of the drug from the risk of the disease itself. Then, we'll see how the complexity of the treatment plan changes the outcomes. And finally, we'll boil it all down into the key clinical takeaways. All right, first up, the landmark pregnancy study. We are looking at a brand new major systematic review and meta-analysis. This research basically pulls together decades of previous work to create one unified, really powerful picture of what's going on. So, what exactly are we talking about when we say anti-seizure medications, or ASMs? Well, while they're the main treatment for epilepsy, their use is actually incredibly broad. You'll see them prescribed all the time for things like migraines, nerve pain, bipolar disorder, even anxiety. And this is so important because it means the findings we're about to talk about are relevant to a much larger group of people than just women with epilepsy. Now, what gives this study its real power is its incredibly smart design. The researchers didn't just compare women on ASMs to a healthy control group. No, they set up 3 distinct groups: women taking the medication, women who had the same underlying disease but were not taking the medication, and then a control group with neither the disease nor the drug. This 3-way comparison is the absolute key that finally allowed them to unlock the answer to that critical question. Are the risks coming from the drug or from the disease itself? Okay, section 2, overall risks identified. Let's take a look at the top-line results when you compare women taking ASMs to that unaffected control group. And the data is, well, it's stark. This table shows what's called the odds ratio for several bad outcomes. So an odds ratio of 1.30, like we see for preterm birth, means the odds of that happening are 30% higher for the group exposed to ASMs. The odds for having a C-section or the baby being small for its gestational age were 43% higher. And for low birth weight, the odds were a staggering 88% higher. The pattern here is really clear, and it's statistically significant. The study's authors really sum it up perfectly. This one sentence, backed by data from nearly 17 million pregnancies, is the definitive top-level finding. It's not ambiguous. Pregnancies exposed to these medications face a whole spectrum of increased risks. So now we've gotten to the absolute core of this entire analysis, and you could argue it's the most important contribution this study makes, untangling the risk of the drug from the risk of the disease. This is where we get the most valuable clinical insight. You know, this is the fundamental question that has challenged doctors and patients for years and years. Where does the risk truly come from? Is it the epilepsy, the migraines, the psychiatric condition, or is it the treatment that you're taking for that condition? And here it is, the study's key insight. By comparing those different groups, the researchers could finally isolate the risks. The column on the left shows the risks that are pretty much tied to the underlying disease itself, like epilepsy. But the column on the right? That reveals the additional independent risk that's added just by taking an ASM. And it's significant. The medication itself was linked to more than double the odds of a spontaneous miscarriage, an 81% increase in the odds of spontaneous fetal loss, and a 40% increase in the odds that the newborn has to be admitted to the NICU. This makes it crystal clear. While the disease carries risk, the medication adds its own distinct and pretty significant burden. The study even offers a potential reason for this. The authors suggest that this strong link to miscarriage might be due to what's known as teratogenic effects. Now, in simple terms, that just means the drugs themselves have the potential to interfere with the normal, healthy development of an embryo or a fetus, which we already know is a cause for a high number of miscarriages. All right, let's move on to our 4th section and see how this all builds.
therapy complexity and outcomes, because the study didn't just stop at drug versus disease. It dug even deeper into how the specifics of the treatment plan really matter.
So the data also reveals a very clear dose-effect relationship. Women who are on what's called polytherapy, that just means taking more than one ASM at the same time, they had significantly higher odds of bad outcomes like preterm birth and low birth weight compared to women who are on just a single medication. The takeaway here is pretty unambiguous. More complexity in the medication plan correlates with more risk. And the analysis also found that not all drugs are created equal. When they looked specifically at the risk of having a baby that is small for its gestational age, or SGA, a clear pattern popped out. Certain drugs, like topiramate and zonisamide, were associated with a higher risk. But in contrast, lamotrigine was associated with a relatively lower or even neutral risk for this specific outcome. And that just reinforces that the choice of the individual medication is a really critical factor. And that brings us to our final section, key clinical takeaways. Let's pull all of this groundbreaking data together and really understand what it means in the real world for both patients and their doctors. Now, to use these findings responsibly, we have to understand their context. Like any research, this study has its limitations. For one, the data is observational, so it's possible that women with more severe disease were more likely to be on medication, and that could influence the results. Also, over 90% of the data comes from women with epilepsy. This means we urgently need more research for that huge population of women taking these drugs for other reasons, like migraines or psychiatric conditions. This research doesn't make the clinical decision easy. What it does is it makes it clearer. The core challenge is still there. A doctor and a patient have to balance the absolute necessity of controlling the mother's symptoms, preventing seizures or suicidal thoughts, against the very real and now quantifiable risks that the medications themselves add to the pregnancy. So, what is the take-home message from this landmark study? Well, first, ASM exposure adds real, measurable risks on top of any risk from the disease itself. Second, using multiple ASMs, that polytherapy we talked about, it makes those risks even bigger. Third, the specific drug you choose matters a lot. And finally, and maybe most importantly, this information is absolutely essential for having a truly informed conversation between a woman and her doctor before she even gets pregnant. And that really brings us to the study's ultimate conclusion and its call to action. This is not just data for a research paper. This is data that's ready to be used today in clinics all over the world to help women make the most informed and empowered decisions they possibly can about their health and the health of their future children.